Hello, teachers, students. My name is David, and I will be doing the narration for Chapter 30 in Maternity and Pediatrics, the Postpartum Family Early Care Needs and Home Care. And before I get into it, I just want to say that in preparing myself for this narration, I really tried my best to put myself in a woman's shoes. So, what I did was I went into my mom's closet and I grabbed a pair of her high heels, and I am currently wearing them. I've also been listening to Shania Twain and the Dixie Chicks all day long, and I'm feeling pretty confident about myself and my ability to do this narration. So yeah, let's get into it. So here are some of the diagnoses for the postpartum patient. Ineffective breastfeeding related to postpartum pain from a cesarean birth or maternal fatigue. Ineffective breastfeeding could also come as a result of the baby just simply not latching on properly. Constipation related to fear of tearing stitches or pain. Constipation could also be from taking narcotics for pain. If they're taking narcotics, they're probably going to be resting quite a bit and they're not going to be ambulating as much. So that would put them at risk for constipation. It would also put them at risk for pulmonary infection. Acute pain related to perineal trauma secondary to episiotomy or birth. Readiness for enhanced knowledge about infant care related to an expressed desire to improve parenting skills. Anxiety related to self and infant care secondary to lack of knowledge of appropriate care practices. Readiness for enhanced coping related to successful adjustment to a new baby. And readiness for enhanced self management related to a desire to obtain optimal health in the postpartum period. And I just want to say real quick that I'm going to try my best not to just simply read the slides. If I have some information that I think would be important to know throughout the presentation, then I'll go ahead and fit that in. So I'll do my best not to just read the slides. But that's probably what I'm going to end up doing anyway. So, all right, promote and restore maternal physical well-being by monitoring the uterine status, the vital signs, the cardiovascular status, the elimination patterns, nutritional needs, sleep and rest, and learning needs. And we'll get more in depth into all of this stuff throughout the presentation. So, following birth, the examination of the uterine status, the lochia, and the episiotomy should be performed every 15 minutes for the first hour, then every 30 minutes for the next 2 hours after that, every hour for the next 2 hours after that, every 4 hours for the next 8 hours, and then 8 hours until discharge. The Bubble He mnemonic for the complete postpartum assessment. On page 736 in your book, there's a really good chart that goes into the normal findings and abnormal findings for all of this. And it also discusses some interventions that you can do or that you can teach the patient to do themselves. For the breasts, they should be soft or filling, no cracking or bleeding. There should be colostrum present. Colostrum is just milk. The uterus should be firm and midline. If it's not midline, that could just simply be because of a full bladder. They might just have to use the bathroom. The bowels, they should have a soft, non-distended abdomen. They should have normal bowel sounds, and the bowel movements should occur without any difficulty. The bladder should be non-distended, non-palpable on exam. They should have adequate voiding, and the urine should be clear and yellow, and it might contain a little bit of lochia. Lochia. If you're like me and you forgot what lochia is, which I did, lochia is just simply the bleeding that occurs after birth. So it shouldn't be heavy in amount. It shouldn't be clotting. It shouldn't be foul smelling. should teach them that perinatal hygiene includes frequent voiding and cleaning their self from the front to the back. And they should use a peri bottle to wash off some of that lochia. And they might possibly get a sitz bath for this. For the episiotomy should have mild edema, should be intact and well approximated. There shouldn't be excessive edema. There shouldn't be any bruising or any sort of discharge. Their hemorrhoids, if they have hemorrhoids, they should be intact. They should be small and non-tender. What would be abnormal is if they were full, tender, and inflamed. And you're going to check their emotional status as well. Methergin. This is an alkaloid that stimulates smooth muscle tissue, particularly that of the uterus. This helps with uterine contractions. If you're not getting uterine contractions, then you could possibly get uterine atony, which is simply the uterus relaxing and not contracting and returning to normal. And this could lead to an early postpartum hemorrhage. The big thing with Methergin, it has a vasoconstrictive effect. So if they already have high blood pressure due to preeclampsia or some other reason, then they shouldn't be getting this drug. So assess their blood pressure before and routinely during administration. Signs of toxicity: nausea, vomiting, headache, muscle pain, cold or numb fingers, or generalized weakness. Episiotomy care. Apply an ice pack to the perineal area for 20 minutes, then remove for 10 minutes throughout the first 2 hours following birth to reduce edema and numb the tissues. To promote healing, use a sitz bath, use a peri bottle, and change the pad following each voiding or defecation, use of analgesics or topical anesthetics, and teach them to tighten their buttocks before sitting. Episiotomy, that's something else that I forgot in the year that we've had since maternity and pediatrics. Episiotomy is just a laceration of the posterior vaginal wall that creates more room for the baby to get through. And something else that is probably important to note here, when using a sitz bath or a peri bottle, make sure that the water is between 38.9 degrees Celsius to 40.6 degrees Celsius. That translates to 102 to 105 degrees Fahrenheit. If it's too hot, it could cause the woman to faint, so it's important not to have that water to be too hot. The position of the top of the fundus following birth. Immediately after birth, it should be in the midline, midway between the symphysis pubis and umbilicus. 6 to 12 hours after birth, it should be midline at the level of the umbilicus. 1 day after birth, it should be midline and 1 finger breadth below the umbilicus. And then 2 days after birth, it should remain midline and descend 1 finger breadth per day. And all of this is in a chart on page 737. So go have a look at that. So here are some commonly used postpartum drugs: Tylenol and Percocet for pain. Again, with Percocet, it's a narcotic, so keep an eye on the respiratory function and keep an eye out for constipation. The rubella vaccine. I think that it's very important to know regarding the rubella vaccine that they should not get pregnant for at least 3 months after receiving that, because it is a live virus. If they got pregnant, that would be very, very bad for the child. RhoGAM prevents sensitization to the Rh factor in Rh negative women, to prevent hemolytic disease of the newborn and subsequent pregnancies, and then Ambien to help them sleep. Some teaching. To relieve after pains, the mother should lie prone with a small pillow under her lower abdomen, and the discomfort may feel intensified for the first 5 minutes but should diminish greatly if not completely. And also, if they've had multiple children or if they have had hydramnios, then they're going to be at greater risk for these after pains. Also, if they're breastfeeding, they're going to be at greater risk for after pains as well. Following the birth, the nurse should assist the mother who may have discomfort from muscle strain or immobility. Depending upon the exertion during the second stage of labor, the mother may experience joint and muscle pain in both the arms and the legs. Early ambulation is encouraged. Early ambulation is encouraged so that it'll reduce the incidence of constipation and also thrombophlebitis, which is basically a blood clot in the leg. To suppress lactation in the mother who chooses not to breastfeed, the nurse should teach that a supportive, tight-fitting bra should be worn continuously within 6 hours following birth. Signs of engorgement will appear by the second or third day postpartum and will continue for 5 to 7 days, and we'll get into engorgement a little bit more in depth later on. Ice packs may be used in the axillary area of the breasts for 20 minutes 4 times per day to relieve discomfort. Ice picks would not be good for relieving discomfort. Also, it's important for them to completely empty out any colostrum that is in their breast. If there's some colostrum that's still in their breast, then that would create a place for bacteria to go, and that could lead to infection, and that could lead to mastitis, which would be bad. Mother may experience emotional stress following birth. She may experience emotional liability with mood swings or tearfulness. She may also experience feelings of inadequacy if she believes she did not cope well with labor. She may experience guilt if the child is premature. The mother should be assured that her feelings are normal and be given a supportive environment that permits her to cry without feeling guilty. So this is sometimes called the baby blues. It is normal. It's caused by a dramatic drop in hormones, particularly estrogen and progesterone, and it can also be caused by sleep deprivation. For some women, it is very severe, though. It's termed postpartum psychoses, and if the mother is crying excessively, if she ever talks about not being a good mother or having the inability to be a good mother, or if she's having difficulty bonding with the baby, then this is something to be cautious of. The baby could actually be at risk of being harmed by the mother if this is going on. So, ambulation and activity. It should increase gradually after birth. The mother should avoid heavy lifting, excessive stair climbing, and strenuous activity. Sexual activity may be resumed after the episiotomy heals and the flow of lochia stops. By the second week at home, the woman may resume light housekeeping, although it is customary to delay returning to work for 6 weeks. Most women are physically able to resume practically all activities by 4 to 5 weeks. In some cases, if bleeding returns, it is often a sign that the mother is overdoing her activities and should decrease some activity. Those are my own thoughts. I didn't read that last part from the book or anything. Family-centered care focuses on keeping the mother and baby together as much as the family desires. This model provides excellent opportunities for the family to bond together, including the mother, the father, the newborn, and siblings. One role of the nurse is to promote parent-infant attachment during the postpartum period. Determine the parenting style and goals of the infant's parents and adapt them into the care plan for the infant. Provide time and privacy for the new family to become acquainted. Arrange the healthcare environment to include a primary nurse to develop rapport and assess the strengths and needs of the family. Use anticipatory guidance to prepare the parents for expected problems of adjustment. Include parents in nursing intervention, planning, and evaluations. Give choices when appropriate. Help parents identify, understand, and accept both positive and negative feelings relating to the parenting experience. Support and assist the parents in determining the personality and unique needs of their infant. Following a cesarean birth, the mother's risk of pulmonary infection is greatly increased because of immobility and use of narcotics. She should be encouraged to turn, cough, and deep breathe every 2 to 4 hours while awake until she ambulates frequently. Again, also with the use of narcotics, be on the lookout for constipation. Interventions for alleviating and coping with pain. Administering analgesics. Promote comfort by frequent position changes, massages, and back rubs. Encourage visits by significant others. Encourage the use of breathing. I think that the use of breathing is very important just for everyday life in general. Relaxation and guided imagery. Postpartum epidural morphine is injected through a catheter directly into the epidural space. It is used to provide relief of pain associated with cesarean birth, extensive episiotomy, or 3rd and 4th degree lacerations. Monitor the patient for late onset respiratory depression, nausea, vomiting, itching, urinary retention, and somnolence. Side effects can be managed with naloxone, which is just used to reverse the side effects of certain narcotics. Additional nursing interventions needed for the mother who underwent an operative birth. So assessing the consistency of the abdomen for firmness and distension or difficulty passing stool or flatus. Assess IV rate, flow rate, site, and patency of tubing. Monitor the condition of surgical dressings or incision using the Rita scale, which is redness, ecchymosis, edema, discharge, and approximation of the suture line. Also, it might be helpful to monitor their temperature too. So in addition to the Rita scale, also monitor their temperature, because if they have a fever, that could be indicative of an infection. Special needs unique to the adolescent mother. The mother should be assessed for level of maturity, their support system, their infant-maternal interaction, discharge plan, knowledge of child rearing, and plans for follow-up care. Contraceptive counseling is recommended because there is such a high rate of repeat pregnancies in adolescents. The adolescent mother appreciates positive feedback about her newborn and her developing maternal response. The mother should be referred to classes where she can learn about infant care skills, peer relationships, added responsibilities, and goal setting. And also, it's important to remember that as a nurse, you can act as a role model with how you are handling the baby and how you act towards the baby. This could be a great influence on an adolescent mother going forward. So some special needs unique to the mother who is relinquishing her infant. Mothers may relinquish their infant because they choose to place their babies up for adoption or because they are serving as a surrogate. The mother who is letting her child be adopted generally has a great deal of ambivalence about the decision and may experience disenfranchised grief. Disenfranchised grief is simply grief that is not recognized or not socially acceptable, and nurses may unintentionally exacerbate this grief by not acknowledging the woman's need to grieve. The nurse should assure the mother that the strong feelings of love and attachment she feels for the infant do not mean her decision to relinquish the child is wrong. So, the mother is ready for discharge when she has normal vital signs. She has appropriate involution of the uterus. Involution is the uterus returning back to its pre-pregnancy state. When she has an appropriate amount of lochia with no signs of infection. When the patient is educated regarding signs of infection, so teach them about the Rita scale and teach them to keep an eye on their temperature. Episiotomy or laceration is well approximated with a decrease in edema or bruising, ability to perform pericare and apply medications to the perineal or anal area, ability to avoid and pass flatus, ability to take food and fluids without difficulty, ability to perform self and newborn care, and they have received rubella vaccine or Rogan if indicated. And again, with the rubella vaccine, be sure to stress the importance of them not getting pregnant within 3 months of getting the rubella vaccine. Some discharge teaching should include postpartum exercise and activity, nutritional needs of breastfeeding or formula feeding mother, proper breastfeeding techniques, basic infant care, process for obtaining infants' birth certificates, when to schedule postpartum and well baby visits, signs of possible complications, information about local agencies and support groups, and a phone number to Mother Baby Unit or information hotline. And here's some additional discharge criteria for the cesarean births. When they state in their own words the reason for the cesarean birth, they maintain a desired pain control, and they maintain a moderate mobility level. So here are some signs of possible complications. These are actually in a chart on page 752. Sudden, persistent, or spiking fever. This could be evidence of an infection. Change in character of lochia. This could be indicative of a postpartum hemorrhage. Pain at the site of laceration, episiotomy, or abdominal incision. This could be evidence of infection. Evidence of infection. This could be evidence of infection. Evidence of mastitis, which is inflammation of the breast. Evidence of thrombophlebitis, which is a blood clot in the leg. Evidence of urinary tract infection, continuing severe or incapacitating postpartum depression, which could be indicative of the postpartum psychoses that I talked about, and an inability to care for self or the baby, which also could be indicative of postpartum psychoses. Possibly, but not necessarily. So, some anticipated outcomes of postpartum nursing care. So the mother is comfortable and had learned pain relief measures. The mother is rested and understands to add more activity gradually. The mother's psychologic and physiologic well-being has been supported. The mother verbalizes understanding of self-care measures. The new parents demonstrate infant care. The parents have had opportunities to form attachment to the new baby, and follow-up care contacts have been initiated as needed. Home care for the mother and the family. During the first home visit, the nurse completes a physical assessment of the mother and a psychosocial assessment of the family. Teaching for self-care is commonly required for new mothers, especially breastfeeding mothers with nipple soreness, engorgement, and other concerns. Family teaching related to resumption of sexual activity and contraception may also be required. Physical assessment focuses on maternal physical adaptation, which is assessed by focusing on their vital signs, their weight, breastfeeding, non-breastfeeding due to mild or moderate tenderness, abdominal musculature, elimination patterns, reproductive tract, lab values, their diet, their fatigue level, and their ability to rest and sleep, pain management, and signs of postpartum complications. Breastfeeding following discharge. Mothers are discharged from the birthing unit before breastfeeding is well established and are frequently alone when they encounter changes in the breastfeeding process. Many women will stop nursing if the situations they encounter seem problematic. Um, they should not do this. They should be encouraged to continue breastfeeding. Regardless of the feeding method, it is important for the nurse to assess the newborn's fluid and nutritional intake. Here are some common breastfeeding problems. Flat or inverted nipples, engorged breasts. Engorged breasts differ from full breasts in that full breasts last about 24 hours. They remain soft and they're not painful. Engorged breasts are hard, painful, warm, and appear taut and shiny, and the consistency is like gravel. I just read that from the book, so I know it to be true. Other breastfeeding problems: large breasts, missed or infrequent feedings, breasts not emptied at feedings. Again, if the breasts aren't emptied at each feeding, then the milk is just sitting there for bacteria to get to it. Inadequate letdown. Letdown happens whenever the baby begins to nurse and the nerves in the breast send signals that release milk. Um, the baby is sleepy or not eager to feed. The mother is overtired or overextended, cracked nipples, plugged ducts, or sore nipples. So here are some concerns about the effects of alcohol and medications while breastfeeding. Alcohol consumption among breastfeeding women should be limited to occasional use after breastfeeding is well established. They shouldn't have any alcohol for at least 3 to 4 hours before nursing. And really they should just wait until after the breastfeeding is done to start drinking alcohol. Medications taken by the breastfeeding mother may penetrate breast milk to some degree. The mother should be advised to inform her healthcare provider and her infant's healthcare provider that she is breastfeeding when a drug is prescribed. If a medication is not compatible with breastfeeding but is needed for only a short time, the mother can use a breast pump to maintain lactation and then discard the milk. And then after she has stopped taking the medication, then she can resume breastfeeding. Alright, some home care for the newborn. The nurse demonstrates methods of positioning and handling a newborn as needed to the parents. As the family members provide care, the nurse can instill confidence by giving them positive feedback. The family member encounters problems. If the family member encounters problems, the nurse can suggest alternatives and serve as a role model. When holding the newborn, the following positions can be used. The cradle hold provides a sense of warmth and closeness and permits eye contact. The upright position provides security and a sense of closeness and is ideal for burping. The football hold, which frees caregivers' hands and permits eye contact and is ideal for carrying or breastfeeding. Bathing the newborn. An actual bath demonstration is the best way for the nurse to provide information about bathing to parents, because excessive bathing and the use of soap remove natural skin oils and dries out the newborn's sensitive skin. Bathing should be done every other day or twice a week. Sponge baths are recommended for the first 2 weeks or until the umbilical cord completely falls off and the umbilicus has healed. Tub baths are given in a small tub after the cord has fallen off and for males when the circumcision site is healed. And you also want to be sure to check the bath water temperature and never put an infant underneath running water. Nail care. Within a week, the nails separate from the skin and frequently break off. If the nails are long or if the newborn is scratching his or her face, the nails may be trimmed. The nails should be cut straight across using adult cuticle scissors or blunt end and flat cuticle scissors. And the infant's nails may also be filed. Dressing the newborn. Newborns need to wear a t-shirt, diaper, and a sleeper. On a fairly cool day, they should be wrapped in a light blanket while being fed. The blanket should be unwrapped or removed when inside a warm building. At home, the amount of clothing should be determined by the temperature. Also, the infant has very sensitive skin, so they could get sunburnt really easily. So whenever going out, just be sure to keep that in mind. Temperature assessment. As the nurse prepares to reach parents about taking their baby's temperature, it is important to provide opportunities for discussion and demonstration. Families often need to review how to take the baby's temperature and when to call their primary care provider. The nurse will discuss the different types of thermometers that are used. The parents need to call the pediatrician immediately if the temperature exceeds 101 rectally or 100.4 degrees Fahrenheit axillary. If the baby is a premature baby and they have an infection, their temperature might be low. So a low temperature in a premature baby would be more indicative of the baby having an infection. Stools and urine. The nurse prepares parents by discussing and showing pictures of meconium stools and transitional stools. Breastfed newborns may have 6 to 10 small semi-liquid yellow stools per day, while formula-fed newborns may have only 1 or 2 stools a day. Babies normally void 5 to 8 times per day. Fewer than 6 to 8 wet diapers a day may indicate that the newborn needs more fluid. Sleep and activity. The newborn demonstrates several different sleep-wake states. 6 newborn sleep-wake states have been identified. It is not uncommon for a newborn to sleep almost continuously for the first 2 to 3 days following birth. And there is a huge chart on pages 770 to 771 that discuss all these different sleep-awake states. Discusses the physical characteristics, the body activity, the eye movements, facial movements, breathing patterns, responses, and caregiver implications regarding all of these different sleep-awake states. So page 770 and 771. And here are those newborn sleep-awake states that are discussed in great detail in the chart that goes from page 770 to 771 in the book. I encourage you to go and look at that because it's very elaborate. There's a lot of detail. So go and take a look. 770, 771. Crying. For the newborn, crying is the only means of expressing their needs vocally. Families learn to distinguish different tones and qualities of the newborn's cry. The amount of crying is highly individual. When crying continues after causes such as discomfort and hunger are eliminated, the newborn may be comforted by swaddling or rocking and other reassuring activities. Excessive crying should be noted and assessed. Coping with prolonged crying may be a challenge for new parents who may respond by withdrawing their affection from the newborn, providing routine care and feeding but not becoming emotionally attached. Others respond by neglecting, abandoning, or even hitting or shaking their newborn. Some cause shaken baby syndrome. This is called abusive head trauma and is often referred to as an intentional injury. So for parents or babysitters of a baby that is prone to excessive crying, I think it's important to realize that if you have a place like a crib, someplace safe to put the baby where you know they're not going to do any harm to themselves, simply putting them down and walking away to recollect yourself for a few minutes, that's not abandoning the baby. You can put them down whenever they're having these episodes and just walk away for a few minutes and gather your thoughts. You don't have to hold on to the baby for the entire period. If it's becoming frustrating, waiting for the baby to stop crying and he or she simply won't, you can put the baby down and walk away for a few minutes, as long as it's in a safe place. Here are some safety concerns. The newborn should not have pillows, blankets, or bumper pads or stuffed animals in the crib while they are asleep, because these cause suffocation. Cribs and mattresses should be checked regularly, and many families, especially those that breastfeed, practice co-sleeping. The infant sleeps with the parents or the mother during the night. The American Academy of Pediatrics does not recommend co-sleeping because it is considered a risk factor for sudden infant death syndrome. If, however, the parents insist on co-sleeping, here's some guidelines that are found on page 772 to 773. Place the infant on a firm mattress, never on comforters, pillows, or waterbed. Never sleep with your infant if you have been using drugs or have become intoxicated. Ensure that the infant is protected from rolling off the bed or becoming entrapped in bed rails or a space between the frame and the mattress. As with crib sleeping, remove all decorative pillows, stuffed animals, toys, or blankets that could impair the baby's breathing. Do not cover the baby with blankets, sheets, or down comforters. Make sure the baby is sleeping on his or her back. Ensure plenty of ventilation to the infant. Avoid overdressing the infant because the parent's body heat will reduce the need for excessive clothing. Never smoke in the bed with the infant. Family members should smoke outdoors and not in the household with the infant. If additional children are sleeping in the bed, make sure they are not sleeping directly next to the infant. These are on pages 772 to 773. So I know that all those guidelines are true. So there are postpartum classes and support groups. Services for families range from education, such as classes on nutrition, exercise, infant care, and parenting, to specific healthcare programs such as well baby checks, immunization clinics, family planning services, and new mother support groups. Postpartum classes are becoming more common as caregivers recognize the continuing needs of the childbearing family. And that is the end. And real quick, I just want to say that going into today, I wasn't really feeling that confident about discussing this topic. I was a little bit intimidated by it, but I pulled it together and I gave what probably isn't the best narration or lecture ever given, but it was pretty close. And for that, I just want to thank my mom for letting me borrow her high heels. Would like to thank Shania Twain and the Dixie Chicks for being so inspirational. And I would also like to thank Beth Oliver, Nancy Tucker, and Stephanie Betts for letting me be in their group. And I hope you all enjoyed it.